pulmonary predisposition to complications during anesthesia and major surgery. So once there is a history that either of the parents have died early, then normally we don't go in for a detailed specialist examination of cardiopulmonary system in younger people, but then in these people, that is one of the things that is recommended. Okay?
चलिए next.
जनरल एग्जामिनेशन.
नहीं अभी एक बहुत इंपॉर्टेंट चीज भूल गए. बहुत इंपॉर्टेंट चीज भूल गए अभी.
What? I can't hear.
See, as on today, you must always ask about drug allergies. If in your case sheet and record you have not mentioned this, that the patient is not allergic or allergic, then probably things are not good. Right? I am talking about this because I am chairman of the ethical committee of MCI also in UP. And I can tell you, most of the cases, as on today, 25% cases are only orthopedic surgeons, remember. Number one. Number two, drug allergies, as on today, do play an important part. Because you keep on writing drugs to a patient of which side effects you are not aware of, number one. Or you have never mentioned in the records that this patient is allergic to this or is not allergic to this. So remember this, whenever you write a case sheet, in block letters you must write on the top of the case sheet whether the patient is allergic or is not allergic.
Would you like to go in for counseling regarding HIV testing? Will you like to go into history and something so that you can decide whether you want to go in for counseling for HIV testing for this patient? He is a young person. What is a high-risk behavior?
You see, when you are asked these questions in an MS examination, you must be able to give an answer. See, don't sit quiet about it. Whether it is necessary, it is not necessary. Whether you like to do it or you would not like to do it. So in your opinion, what do you think should be done?
Should be done for all
Should
cases.
be done.
Yeah,
Right?
particularly when we are
Now the
planning
question is, counseling should be done after the patient has been found positive or it should be done before that?
before.
Why? You don't know whether it's positive or negative.
Yeah, we should.
So what counseling are you going to do?
We should check for. If it is positive only we can do. Check for the HIV status.
Because if you ask this to each and every patient who comes to you, probably he'll eat your head.
So what are the features in history that will help you make you decide that this patient requires counseling? Or you just want to go in for HIV testing? Sister, iska HIV testing kara lena. Can you go in for that like that?
One is occupation.
You have to counsel the patient. See, it is mandatory that you cannot go in for these investigations without explicit consent of the patient. And the consent is taken only after proper counseling. And counseling is done only in those patients who are, in your belief, are a high-risk group. So you take a history to decide whether this patient belongs to a high-risk group.
So what are the
What are the points that make a patient a high-risk group?
See, occupation, one is the.
You can speak out.
One is the occupation.
Occupation,
What
yes,
occupation?
very good.
What occupation?
So, mobile like lorry driver.
Truck drivers, very
Truck
good.
driver.
Yes, truck drivers is one people who are relatively less educated and move out of their houses for longer period of time. That makes them more prone to high-risk behavior. And then, of course, sex workers, drug addicts, and people who are exposed to surgical trauma or exposed to hospitalization. Again.
ठीक है बेटे? So you must understand. Now, there's one question which was raised. In which cases, or you have to take consent before HIV testing? Ideally, truthfully, yes. But in emergency, if the cases are coming to you, I think each and every hospital now gets a HIV done without any consent. Am I right? Am I wrong?
It has become mandatory.
It has become mandatory.
It
In
is-
our
it is
hospital, it is mandatory now.
Actually,
We don't take consent, but it is mandatory. We don't disclose. That's a different story.
legally.
We don't
legally-
disclose.
Legally, you cannot do it. Legally, you are supposed to take universal precautions. In every patient, you have to treat that patient as having HIV, and you operate and behave with the patient as if he's having HIV. That is what the legal provision is. If you are getting an HIV testing done without the patient consent, it is illegal. Okay?
I agree, but the basic fundamental principles that we are following today is we get it done. If it is positive, we counsel. No confusion.
But it is
But we don't disclose to anybody whether he is positive or is negative. Right? Chali, let's proceed further. So let's come to the examination now.
general examination. The patient is moderately built, well nourished, no pallor, not icteric, no cyanosis, and no generalized lymphadenopathy. Local examination.
What is important in a physical examination? Anemia, you said, everything you said. What is one important thing which is very important?
Tuberculosis.
Pardon?
History is future suggestion of tuberculosis.
No, no,
That's
no.
history.
That is
We're talking
history.
of
Examination.
Built, wasting.
See, to my mind, you ask for everything, clubbing, cyanosis, anemia, everything. But one thing which is important is septic foci in the body. History of any septic foci in the body. Now, where are the places that you ask that the patient has got a septic foci? Look for septic foci.
Throat,
Okay, throat is one. Now, I would like you to answer from top to bottom, from head to down.
skin lesions, ear discharge,
Dekho, some things are very obvious, which you can see. If there's an eczema, carbuncle, furuncle on a skin, you'll be able to see. Now, you have to look for those sites where you're not able to see. Scalp is one, because the hairs, you're not able to see. Right? Then, armpits, groin, genitalia. These are important aspects where you have septic foci not able to see. Then ear, of course, nose, throat.
dental infection,
Right. And why is it important?
surgical,
In a Western world, if you're writing a case sheet and you don't mention about this, probably you'll never pass. The reason is, you are putting in implants, you're doing a lot of surgeries, and all these, you have to treat the septic, in an elective case, you have to treat the septic foci before you go for any surgical intervention. So remember this. Chaliye. So general examination, there's nothing important,
yes,
no septic foci,
no septic,
right? Okay.
local examination.
Systemic?
Sir,
What about systemic examination?
systemic examination,
Now, why is local and systemic examination important? One is to, basically, it's not the point of focus of the pain and not inability to walk. Our focus is to treat this patient as a whole, to know what his other medical problems are, right? Which may affect his surgical intervention or his management. So, physical examination and and systemic examination, general and systemic examination is important so that we examine this patient as a whole. If he has, suppose we find out that he's got some chest problem, he's got some lung problem, he's got some cardiac problem, then of course, apart from treating our problem, he has to be guided, counseled for those problems also. Right? Come to the local examination.
local examination, inspection with the patient in lying,
Again. Hip examination requires a methodical examination and a methodical answer. So what do you start with?
inspection, attitude,
Even before attitude, I want you to tell me something else.
gait,
Whether the patient can stand or he cannot stand, number one. If he can stand, whether he can weight bear on that limb or he cannot weight bear on that limb. If he can weight bear on that hip, can he walk or he cannot walk? If he can walk, what is the gait of the patient? Next, whether the patient can squat or he cannot squat, whether the patient can sit cross-legged or he cannot sit cross-legged. At the same time, when the patient is standing, I want you to speak about the spine of that patient. Before we come to the local examination, this examination is a must, no confusion. If the patient can stand, then you have to examine him from the front, from the back, from the side. Right? Then we come to the patient lying down on the case. Now what has happened with the present graduates which are passing out, they don't focus on the clinical, and in a maximum of the cases fail in hip examination. Though it's so methodical, if you carry it on methodically, probably you can never fail. You will always jump on to the investigations. What is the need? You get an X-ray done, see what is the cause, what is the problem. Right? But in DNB and MS, this is a priority. If you are not able to give us a good clinical examination, probably things are not good. Right? So, can the patient stand?
Okay, standing with the support.
So, he can stand, but he cannot weight bear on that
Weight bear
limb.
on the limb.
So, gait cannot be commented on.
Yes.
Right?
Yes.
Okay. So, you have examined the patient lying down.
Yes.
Okay, carry on now.
With the patient lying down on supine on the couch, with the patient in supine position, the attitude
Now
of the
again, before you do that, what is more important is the exposure of the patient,
exposed. Yes.
right? So
Exposed
exposure
from
should be,
umbilicus to the
probably the whole body should be exposed except the part which is to be covered.
private area.
Number one. Number two, the room temperature should be good. You should not expose a patient in a cold atmosphere. See, all this is observed when you're examining the patient. The moment you start examining the patient, the examiner is watching you. Whether you've made the patient comfortable, have you counseled the patient what you are going to do, have you exposed him properly, is the temperature of the room congenial? If it is not, then you have to make it. Now, what I advise my postgraduates these days, take a shot with you, a Frenchie or a small, if it's a female, a small this thing. Carry it in your pocket. If you get a case, you ask the patient to wear that and donate it to that patient. That is what I am doing in my department. All my postgraduates, when they come for the exam, they carry this with them. Make sure that the patient is comfortable, make sure that the patient is exposed well, and they donate it to that patient. I expect this from you all also.
You can use the disposable diapers also.
Right, so exposure is important, the atmosphere in which you are examining the patient is important. Before examination, now the counseling starts. What are you going to do? What are you going to examine? How you are going to examine? Is all that is important when you examine a patient. Right, so here the exposure is bad. There's no exposure for the time being. Chaliye.
Exposed from umbilicus up to the umbilicus.
Ask the patient to lie straight. Okay.
With the
Going on. नहीं रहने दो, इधर तुम इधर आ जाओ, जब बताएं जब तू उधर चले जाना.
अरे कैमरे वाले भाई साहब आप फटे हैं, बोल रहे हैं डॉक्टर साहब को थोड़ी हटाने को बोल रहे हैं. शादी में करते हैं ऐसा.
Chaliye, anyway, let's have the sequence of how we examine the patient. So what do you observe now? On inspection,
On inspection, attitude of the left lower limb, the hip in neutral position, the patella facing externally, and the ankle in plantigate position.
what do you mean by the word hip in neutral position?
There is no.
I'm telling you, in an exam, don't use adjectives. The moment you start using adjectives, you expose yourself. Right? So how will you describe this attitude? Patient lying supine on bed, both limbs parallel to each other, and left lower limb externally rotated as compared to the right. Right? This is the attitude. If he has a flexion deformity, talk about the flexion deformity. Right? So at present the attitude is left lower limb is lying externally rotated as compared to the right. More external rotation on the left side as compared to the right side. Right? Chaliye, ab aage badhiye.
Left lower limb appears to be shortened compared to the right side.
No, again. You got to go from top to bottom. The moment you start doing short, wasting, I think you'll forget, your sequence goes wrong. Now what is the sequence? How do you examine the hip?
From anti-superior iliac spine.
No, before that something else.
Spine.
So it's lumbar lordosis which comes first.
So the examination from the sides, we can tell.
That's what you got to. You see, now again, there's a controversy. You will waste time. When you're examining a hip, you have already examined the hip. Right? If you say front se ye hai, back se hai, side se hai, I don't think it carries any significance. Okay? So what we want is your examination should be quick, it should be discreet, it should be correct. Okay? So if you want to speak from front first and then you got to go from the side, then from the back, probably you're repeating things. Okay? So let's start with the sequence that we normally follow.
There is exaggerated lumbar lordosis.
There is exaggerated lumbar lordosis.
Yes.
How do you say that there is exaggerated lumbar lordosis?
We can see the opposite side.
Right, you sit down to the level, sit down to that level. See if you can see through and through.
Yes. You can see the opposite side.
See, with the shirt folded, you can obviously see through the whole side.
Then
So
when we
that's why the
pass,
importance of taking off all the clothes. With the fold of shirt there, that may be the cause of increased lumbar lordosis.
Okay, what does increased lumbar lordosis tell us?
it has a fixed flexion deformity of the hip.
That the patient has got a fixed flexion deformity. Okay. And how do you confirm that this patient has got a lumbar
By
lordosis?
doing a Thomas test.
Right, you do a
Thomas test.
Thomas's hip knee flexion test. How do you do a Thomas's hip knee flexion test?
With the patient supine, first we have to insinuate our hand into the lumbar, behind the lumbar spine. Then the normal hip should be flexed so that lumbar lordosis is obliterated.
Do it, let's see.
The patient is asked to hold the,
Now, do you think this patient has got a lumbar lordosis?
sir?
Do you think this patient has got a lumbar lordosis?
Yes.
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 But the other limb is an extension. There's no flexion that limb. There's another word of piece of advice I like to give you today. Check, counter check and check. If he has a fixed flexion deformity, then only the lumbar lordosis will be there.
See, I told
he's
you
having
there
a
is a
50
fold of
15
cloth
degree.
there. There's a
50.
fold of cloth there that is causing him to, and if you want to insinuate your hand in a lumbar spine which is not lordotic, automatically the patient will make it lordotic. So you have to take off the clothes first. Don't insinuate your hand. You insinuate your hand only when visually you confirm that there is a lumbar lordosis.
You got 15 degree of fixed flexion deformity.
Show me. I don't think he has any flexion deformity.
He is wearing something inside.
Yes.
Take off his clothes. For a moment, take off his clothes.
No problem.
ये निकाल लो.
Take it off completely and take off his shirt also. आराम से सो जाओ, जरा ढीला छोड़ो.
lumbar lordosis तो है.
Yes.
बिल्कुल बिल्कुल. Right. Yes, agreed. Right.
Hold. Right.
You tell the method. So that
The patient is asked to hold the right knee so that the lumbar spine touches the knuckle and the lumbar lordosis is obliterated. Sir? Sir?
when you are flexing the normally lumbar spine will touch the knuckle.
No, it will be totally obliterated.
You cannot insinuate your finger
Cannot
in
insinuate.
between. Then what? Means is you cannot see anything from this side. Okay.
Yes.
Then
we assess the degree of deformity.
but you should tell something to the patient.
The
Na?
patient is asked to hold the.
Yes. Now you have obliterated. Then
The patient is asked to keep the same position.
Keeping your hand there, you ask the patient to extend the abnormal limb.
isn't it?
The moment the lumbar lordosis appears, that is the fixed flexion deformity of the limb. I hope you get it. You see, we have insinuated your hand.
Yes.
You asked, obliterate the lumbar lordosis. You ask the patient to hold that limb in that position, keeping your hand and under the lumbar spine. Then you ask the patient to extend the abnormal limb. The moment the lumbar lordosis appears again, that is the fixed flexion deformity. Still not sure.
What we have been taught is
Yes.
by this.
He is telling that when the abdominal limb will extend, the amount it sustains to the couch is the flexion deformity. He has
Yeah.
been taught like that.
The degree it substance with the couch, we will measure it as.
I think I am also saying the same thing.
Yeah.
Because once you have flexed it, probably the flexion deformity is more. Right?
He moves his limb more.
More. And when he tries to extend it, it starts appearing again. So to find out the exact flexion deformity, you have to ask or you do it passively or ask the patient to extend. Right? And the moment your hand feels that the lumbar lordosis starts appearing, that is the true fixed flexion deformity. Okay? Chaliye, next. So according to you, this patient has got a flexion deformity of 5 to 10 degrees. Again, another piece of caution. 5 degrees does not make any difference.
15 degree.
You should not tell.
10 degrees should not tell.
Because like I got confused or you got confused, see, if the limb is straight, probably don't speak about it. Okay? Don't make the examiner come to the patient.
If the situation is such that you are having a lumbar lordosis when you extend the right hip, and when you flex the right hip, the lumbar lordosis is obliterated, but there is no flexion deformity on the left hip. What do you interpret? Could there be some pathology on the right side?
Yeah, it may be bilateral fixed flexion deformity.
That's one of the possibilities.
So lumbar lordosis you talked about. Next thing you talk about is
Level of anterior iliac spine.
anterior spine.
The left anterior iliac spine appears to be at higher level.
Now,
compared to the
before you speak this, higher level or lower level, I am sure you always confirm it before speaking. Okay? Confirm twice before you speak that. Okay? So if it is AS as a higher level, what does it indicate?
It is a adduction deformity.
A fixed adduction deformity.
Fixed adduction.
And if it is a lower level, it means
Fixed
a
abduction.
fixed abduction deformity.
Which ASIS is higher in this?
Left anterior iliac spine is higher level compared to the right.
And how do you palpate the ASIS?
We palpate along the inguinal ligament, the first bony prominence felt.
Right. So any bony landmark that you palpate is from soft tissue to the bone. Right? Whether it's the greater trochanter, whether it's the ASIS, whether it's the pubic tubercle, whatever it is, always go from the soft tissue to the bone. Okay, so ASIS on the left side is at a higher level.
Yes.
Next. Top to bottom. So you talked about,
There is no fullness of scarpus triangle.
very good, you talk about fullness.
There
Fullness
is
and skin around the hip.
the skin is no scars, no sinuses, no dilated veins. There is the left thigh seems to be wasted compared to the right.
Very good.
Then there is a
Now before that you must speak about something. If it's a thin patient, you must be able to talk about the trochanter. Right? In a bulky patient you not be able to, but in a thin patient, next in hierarchy comes the trochanter. After the trochanter it is the wasting. And after the wasting it is?
So I will first finish side, front side.
The shortening. Of course, you talk
Yeah,
about the
coming
level
down.
of the malleolus and the patella facing laterally.
Yeah, coming down, sir. From the there is a
So the positive findings are, according to lumbar lordosis, ASI is at a higher level, right?
Yes.
Wasting and
wasting-
shortening
Yes, shortening.
and external rotation,
Yes,
right?
yes.
चलिए आगे बढ़िए.
Palpation. Palpation. There is hip joint, anti-hip joint tenderness present.
What do you look for first before tenderness?
Warmth.
Warmth. So palpate the.
There is no local rise in temperature.
Mhm.
There is anti-joint line tenderness is present.
Tenderness is present where?
Anti-joint line tenderness. For the left hip. Sir,
Where is the tenderness?
joint line tenderness anteriorly.
What do you mean by joint line tenderness?
It is
Where is the joint line?
1.75 centimeter below and lateral to the mid-inguinal point.
So do you call it something? This is what I am trying to convey to you. Talk in terms of anatomical terms. When you're talking about tenderness, talk about anatomical terms. Scarpus triangle, greater trochanter. What is anterior joint line tenderness and what is posterior joint line tenderness? They are not anatomical points. An anterior joint line tenderness does not lead me anywhere. But scarpus triangle tenderness leads me to a clue. Right? So you mean to say there's tenderness in the scarpus triangle,
Yes, base of the scarpus.
base of the scarpus triangle. Chaliye, आगे.
There's a tenderness there.
Yes, tenderness was left side.
How did you confirm? Can you show it to us?
There's no significance of bitrochanteric tenderness. Because when you are pressing the trochanter, the lesion can be anywhere. Right? Right from the acetabulum to the neck to the trochanter. So I don't think it has got any significance. Right? So when you're talking about the trochanter, what do you look for in the trochanter? One is tenderness. What next?
Yeah, level of the trochanter.
Okay, level of the trochanter, very good. What else?
Regular or
Regular or irregular. Next? Broadening.
broadening.
Right? Thickening, broadening, level and tenderness. Okay? कुछ है कि नहीं है?
Tenderness is there.
कैसे tenderness देखा आपने? Other than
How-
bitrochanteric compression, do you have any other method?
No,
Is
You
it
don't have it?
tender?
You hold the
Fingers on the back and thumb on the anterior.
hold the trochanter and see whether it is tender.
Then only you will
mildly
be able to know whether it's broadened or not. You have to hold it anteroposteriorly.
And press that time.
he's saying mild tenderness was left side.
So
So then,
I hope you understand now, bitrochanteric tenderness does not lead you anywhere.
Forget it.
Don't talk about it. A specific anatomic point has to be tender, right? And greater trochanter, you always palpate anteroposteriorly. You look for the broadening, you look for tenderness, and you palpate to think for irregularity or thickening. And of course, you palpate whether it is up or not. So is it up?
It has gone up.
Yes, trochanter is elevated over the left
So
side.
positive finding is tenderness in the
Tenderness
scarpa
of the
triangle, greater trochanter is at higher level.
Yes,
Am I right?
yes.
Okay. Let's proceed further. What else? So अभी तक हमें
Inspection and palpation.
फ्लेक्शन डिफॉर्मिटी मिली है तुम्हारे हिसाब से, ASIS हायर लेवल पे है, टेंडरनेस कार्पस ट्रायंगल पे मिली है एंड ग्रेटर ट्रोकेंटर एट हायर लेवल, राइट?
Yes.
चलिए आगे बढ़िए. नेक्स्ट फेज क्या आता है?
We'll look for deformities, adduction and abduction deformity. We have to look.
वेरी गुड. वो मूवमेंट्स में देखते हैं. यू राइट.
You see for the movement.
Yeah.
There you tell deformity.
Movements, deformities. The first. We will squaring the pelvis. There is adduction
Has he
deformity.
got active movements?
So first I will describe deformity
You should
and
see
then
two movements,
go for
active
movement.
and passive. Active movement has he got?
Yeah, it's painful.
No, has he got at all?
Yes,
He is able to flex.
up to 20 degree.
No, you ask him.
पैर ऊपर उठो.
He is not able to raise from the ground.
So it is whenever you look for movements, you must see for active movements and passive movements. And here also you can also comment whether the patient can lift the limb in air or not himself, right?
He must lift in the air, otherwise he can drag it.
So what he is doing now is only contracting the muscles. He is not able to do any active movement as far as the left hip is
Active
concerned.
movement is zero. In all directions.
Yes.
Right? So you must talk about passive movements now. Carry on.
First deformity and then movements.
Carry on. Carry on.
By squaring
So
the
you squared the pelvis.
squaring the pelvis.
Okay.
How do you square? No, you tell.
First.
I know you know it. Just tell.
First we have to mark both anterior superior iliac spine.
Very good.
We have to place a thumb over the one anterior superior iliac spine and a middle finger over the other. Then we have to hold the both legs
You have marked two anterior superior iliac spine. Then what will you do? Next step.
to mark.
They are not in the same level.
Yeah, not in the same. Left side is elevated.
The affected side has gone up.
Yep.
So what will you do?
We have to hold the both legs
Both
and
legs.
sir, both lower limb.
That's what I was trying to ask you. How do you
Square the pelvis. That is enough.
You mark the ASIS.
Bring the both anterior superior to the same level
How?
by dragging the legs.
Dragging.
Moving.
See, both limbs are parallel.
Adducting and abducting
Both
them.
limbs are parallel
Yes,
to each other, right? One ASIS is at a higher level. So you got to bring the affected limb into adduction.
So by adducting I am able to bring the
Yes.
left anterior superior.
Adduction
spine.
deformity, further adduction.
Yes.
Abduction deformity, further
Further
abduction.
Yes.
So once they come to the same level, then what will you do?
We will measure the deformity.
There is another step. You keep the other limb in identical position, then take the measurement.
We talk
Then
about
the
movements first.
Only movement.
Movements first. You're right. So you put the limb to adduction. How much is the adduction deformity?
20 degrees.
20 degrees.
How could you
Now
know?
talk about the movement.
There
20
is,
degrees of adduction deformity.
How could you know?
sir,
How could you know it is 20 degree?
how did you know?
You have squared.
Like
Then there is one big sharp angle, na?
Sir,
Kothari's angle.
How did you measure the deformity?
by with the vertical lines, with the
Yes.
midline.
Midline you can do,
Yes.
or you can join this. What previously, now it has come to the angle which is certain also is the deformity for the abduction or adduction deformity.
There is
Kothari's angle.
Kotaris.
So you have measured the adduction deformity. What do you do now? I mean, you shouldn't take that long. You're showing us the movements.
Movements.
So he's got a fixed adduction deformity of 20
20
degrees.
degrees.
Proceed further.
There is no active movement. Passive movement, flexion 0 to 100 degree, further flexion is painful.
So 0 to 100 degrees, further flexion is painful. 0 to 100 is painless.
Yes.
Right.
More than 100 is painful.
There is extension of 0 degree. There is no abduction. There is fixed adduction deformity of 20 degree.
There's no abduction at all.
There is no abduction.
There's no abduction at all. And how much is the adduction?
20 to
How much is the adduction?
20 to 40 degree.
20?
To 40.
20 to 40. So range of adduction is 20 degrees.
Yes.
From fixed like adduction of 20 to 40 degrees. Now, is it painful, painless?
Painless.
See, whenever you talk about movements, you must tell us the range, number one. You must tell whether it is painful or painless, right? You must tell whether it is associated with any sound or not. You must tell us whether it is stable or it is unstable. Okay? So according to you, this patient has got 20 degrees of adduction deformity with a further range of 20 to 40. There's a flexion movement of 0 to 100 degrees.
100 degrees.
Further attempt to flex is painful.
Painful.
There's no abduction. And there's no, is there any extension?
There is no extension.
There's no extension.
And telescopy is positive on left side.
Can you demonstrate the abduction?
Sir?
Can you demonstrate absence of abduction in this?
After squaring the pelvis, when the affected limb is attempted to abduct, the pelvis is moving.
You demonstrate to us.
Telescopic post.
Yes.
Abduction है कि नहीं है?
No. Pelvis is moving.
हैं?
No.
Pelvis is moving.
Yes.
No.
From normal you are going abducting or adducting to abnormal? What you are telling?
He is saying fixed adduction deformity.
Then you come to normal. Yes. No. Means he is not able to, you are not able to bring to the
Check
normal.
करो यार.
Yes.
Naturally. When is the adduction deformity? Abduction is zero.
Zeros.
इसमें है abduction भी होगा इसमें.
ये सामने से
मसाज की हिस्ट्री है.
now his pelvis is square. Okay, to prevent the pelvis from rotating, my hands are large, so I can put the fingers on both the ASIs. Okay, and gently, without hurting him, I try to bring this in abduction. ढीला छोड़ो, ढीला छोड़ दो, ढीला छोड़ो. There is no movement of the pelvis. There is no movement of the pelvis. What you were doing, you were trying to do it with a jerk. The moment you tried to move it with a jerk, he would
Spasm.
make his muscles spastic, and see now, he has a square pelvis and that much of abduction. So you realize if your technical fault, what went wrong?
Done gently.
Yeah. See, the moment you said that a patient is having positive telescoping, he could not have had a fixed adduction deformity. Positive telescoping requires a lot of laxity of capsule, so that was not conducive with any deformity. Okay?
Now, a piece of advice once more. As Dr. Sahib has told you, you must be very patient with this. You must have patience with the patient. You must examine in a comfortable manner, right? Not with jerks, number one. Secondly, if you have telescopy, right? Probably both abduction and adduction will be positive, because the movement is taking where? It's taking at the fracture site,
Fracture site.
right? So in old cases, you may have, because that is why I asked you the history of massage. If you have a history of massage, probably, and with telescopy, probably the problem is where? The neck is not there. Probably the neck is not there, right?
Yes.
And probably the patient will have abduction. So if you have abduction, then probably the fixed adduction deformity is not there. Go and check again at the SIS, and it will be very comfortable to say that ASIS are at the same level. ठीक है ना? So this is a piece of advice in MS exam. If you find that the opposite movement is there, go and check it again. Either you are wrong or your examination is wrong. But mathematics cannot be wrong.
One thing, can I ask you to my seniors here? just by the way, whenever we are seeing in case of fracture neck of femur, the movement is occurring at the fracture site, but we are paradoxically telling it is the movement of the hip. Sir, Dada, apni ekটু bolun. When we are going to look for this movement of the joint, the acetabulum is not going around this head is not going inside the acetabulum. It is the fracture site where all these movements are taking place. Then what is the use of taking this, all this, breaking your head for this movement?
I think it is not the movements. What we are talking about, fixed deformities.
Okay,
We are talking about fixed deformities. We are not.
or the stability. The stability is telescopic is positive, finished.
Again, telescopy may be positive, but we talk about fixed deformities. Fixed flexion, fixed adduction, fixed abduction, and fundamental principle says that if is a fixed.
Written in the book, we are just following. Because whatever movement we are going to see, it is occurring at the fracture site, not in the joint line.
But we cannot differentiate this.
And when the patient is not able to manifest any active movement and the passive movement is painful, following it from what?
I think we'll discuss it later, but yes, for you have to do a movement, you have to find out what is,
You have to do all this.
you have to find out what is the fixed deformity and what is not a fixed deformity. Remember, if you have both movements, ASIS has to be at the same level. Then of course you talked about telescopy. How do you look for telescopy?
Did you see telescopic?
Prerequisite for a telescopy, let us tell, just tell.
2 years of telescopic test. Just tell.
पेशेंट दिखाओ.
On the right side you can show.
पेशेंट दिखाओ. हमारी थोड़ी फोटो देखने के लिए आया.
हम सब बूढ़ा हो गए, हमारा फोटो जरूरत नहीं.
What are the prerequisites for a telescopy test?
Yes. Patient is in supine position.
What do you mean by prerequisite?
These are
Necessary
the
conditions.
Necessary conditions.
Without them, the test cannot be done. Okay? So what are the prerequisites here?
Should have a relatively painless hip.
One is pain should be.
Right. And the hip should be, he should be able to flex you should be able to flex the limb to 90 degrees.
Yes.
Knee. If knee is fixed,
Knee is also 90 degree flexion.
Naturally.
No, but you can still, theoretically still.
Okay.
Can you demonstrate the telescoping test here?
so on the right side.
You have to hold the trochanter with the finger and anterior to be place the thumb.
You have to fix the pelvis. You have to fix the pelvis.
Fix the
So your
pelvis.
thumb should be on the ASIS,
Anticipate.
middle finger on the greater trochanter, flex, push it down, push it up, push it down.
You look for relative movement between ASIS and trochanter.
Yes.
Normally this movement is not there. If the movement is there, that means there is a discontinuity between the shaft and the pelvis.
Pelvis.
So,
If the head has gone out,
Sir,
if the head has gone out,
there will be positive.
dislocation hip,
You can palpate the head if it's a dislocation.
Even if the head has gone out.
relative movement of the greater trochanter you look for. Relative movement of the greater trochanter.
palpate the movement of the greater trochanter by your 4 fingers keeping on the lateral side. what's
Trochanter. Posterior.
ठीक है? चलिए, next thing. So positive findings, lumbar lordosis, ASIS is the same level now, right? Tenderness in the scarpa's triangle, greater trochanter at a higher level, smooth, not broadened, right? Measurements रह गए. Measurements.
Measurements, there is supratrochanteric shortening of
So I think we talk about two measurements.
apparent and true.
We talk about two measurements, apparent and true. Apparent is only significant and the prerequisite is that the limb should be parallel to each other. If there is a gross deformity in one limb, apparent measurement does not hold any significance. So prerequisite, limb should be parallel to each other from xiphisternum to the medial malleus, right?
Point you take in the middle.
Now coming to true measurements,
from
we basically make the pelvis square, keep both limbs in identical position and from ASIS to the knee joint line and from the knee joint line to the medial malleus, right? Because we want to measure the segments of the limb also, the thigh, the leg and supratrochanteric. And we confirm it by what?
Sir?
Bryant's triangle,
Bryant's triangle confirm.
right? So this,
Points in branch triangle?
Sir,
Which point you will join to form the branch triangle?
base of the triangle.
no, the
Only
points.
anticipient spine, tip of trochanter. We will mark the 2 points by a line and another vertical line down perpendicular to the couch from anticipient spine. We have to connect that line to the tip of trochanter line.
Okay.
That tells the base of the branch triangle.
So you measure the base of the
Branch triangle.
branch triangle.
It is
Now,
short.
what is your provisional diagnosis? I think time is running short, so I'm going a bit in hurry manner. So what is your differential diagnosis now?
It is a case of unstable hip.
No, this is not the diagnosis. This is not the diagnosis.
Anatomical.
You have taken history, everything examination unstable.
Probably due to
22 years old male, 2.5 months old. Yes? Next. What is your provisional diagnosis? This you have to say. 22 years old male, 2.5 months old,
probably non-union fracture neck of femur.
ununited fracture neck of femur left side,
Left
number
side.
1. Next, second diagnosis. I told you, you must have all things in mind. Whatever lesions in that area because of this problem, you must put in the differential diagnosis. So the differential diagnosis can be
Either
an intertrochanteric fracture of the left femur. Right? Now what are the points in favor of fracture neck femur?
history of trauma.
These are typical questions that I have asked from you. What are the points in favor of fracture neck femur?
History of trauma.
Very good. Age is not in favor, number 1. Right? So history of trauma, following which the patient was not able to walk.
Not able to walk.
Right? There is no history of treatment taken. The patient has not been able to walk and is not able to bear weight till now. Right? Next.
Telescopy was positive.
Again, why tell, you see, when we start from physical, I have started from history. Your answer should be general examination and then systemic and then local examination. So general systemic, we don't have anything positive, right? In local examination, we find that the patient has got a lumbar lordosis, a fixed flexion deformity of 15 degrees according to you.
Tenderness.
Tenderness in the Scarpa's triangle. The trochanter is smooth, non-tender, and it has gone up. It's not broadened. Then there is a shortening and external rotation deformity. These are points in favor of fracture neck femur. Points against fracture neck femur, more external rotation as compared to the right side. But in old cases of fracture neck femur, you do get external rotation more because of the
Abductor.
capsule elongation, because the attitude, right? So this is a case of probably ununited fracture neck of femur, 2.5 months old. How will you proceed to manage this case now?
Investigations, radiograph.
What X-ray?
X-ray of the pelvis with both hips and X-ray of the left
Right, X-ray pelvis with both hips AP view and X-ray left hip lateral view, right?
traction internal rotation view.
And in 15 degrees of internal rotation so that you can see the whole of the neck. Okay? ठीक है?
Do you happen to have X-ray?
Do we have an X-ray here?
Another question can I ask you? You are confident.
वो बाद में पूछ लेना सर. Right? Now, 2.5 months old. नहीं कर रहे हैं बस. Let's see the X-ray. See the X-ray. I mean, final discussion of the X-ray and then we forget about the chest. Show the X-ray यार. आएगा नहीं इसमें. दिखाओ इधर दिखाओ.
उसके लाइट को सफेद कर दो, इमेज खत्म कर दो उसकी. कंप्यूटर से डिस्कनेक्ट करना.
Dada, everywhere we tell non-union, except neck of femur, where we tell on-union. Why?
Ununited. अभी बताता हूँ मैं. I'll tell you.
I have collected all these paradoxical things into consideration.
दिखाना X-ray दिखाओ इधर दिखाओ.
Yeah.
I'll read the. You have seen the X-ray? Kindly read the X-ray fast.
No, I have not seen.
You have not seen the X-ray.
A good boy. Because he had not seen the X-ray and examined the case.
देखो यार X-ray देखो, जल्दी देखो बेटा. You can see it in light, यार. You can see it. So what are the things you look for in an X-ray? The fracture line, number 1.
Yes. Break in
Shenton's line number 2.
Break in Shenton line.
Greater trochanter at higher level, lesser trochanter more prominent, right? Then you look for the head, you look for the acetabulum,
Acetabulum changes.
right?
Yes, sir.
And you look for the quality of bone. So fracture line, Shenton's line, greater trochanter, lesser trochanter. Head is vascular or avascular, number 1. Acetabulum is okay, the joint line is fine or it is not fine, and osteoporosis is there or it is not there. So in this case, what I personally see is that the neck seems to be absorbed. Right?
Yes.
The acetabulum is fine,
Compared to the
head cannot be commented on, right? And all the other positive findings for united fracture neck for femur are there. Am I right?
Yes.
Right. So how will you manage it now? 2.5 months old, 22 years old male. What are the options?
We have to.
Now again, the controversies which arises, how do you make sure that the head is vascular or it is avascular? How do you know it?
MRI.
Get an MRI done. So MRI is the first thing that you might get it done.
If the head is avascular, what will you do? At 22 years, would you like to replace it? What is the recommendation of literature? Whether it is avascular or vascular,
You have to preserve.
To preserve it. So MRI exactly is not mandatory when you want to do it. Theoretically, yes, when you want to determine whether it is vascular, you may have to tell the patient, and for that reason you might have to get an MRI done.
Come on, let's see the options now.
Yes,
You have to preserve the head.
yes.
Basic fundamental is you have to preserve the head. How can you preserve the head? Neck is slightly absorbed, right? And you have to preserve the head.
Muscle pedicle bone graft.
Option is number 1, reconstruction, bone grafting and fixation. Number 2, displacement angulation of valgus osteotomy.
Valgus osteotomy. Bone.
With or without bone grafting?
Bone grafting.
Bone grafting may be Mayer's procedure, right? It may be a graft, right? Or you put in, there may be many ways. You put in a fibula graft, you open the neck, you reconstruct the neck, fibula graft, cancellous screws, fix it, do a massive muscle pedicle graft. This is one stage. Second is you can do a displacement angulation osteotomy, valgus osteotomy. So these two options are there, right? Third option, as rightly said, some people
Do replace.
in the best of the world, they may go in for an MRI. If you feel it is avascular, they may tell to the patient and give him a good quality of life, but probably you will not mention it, right? You can think of a bipolar at this stage, right? Because as the things are advancing, quality of life also matters. Anything else? Right? कर लो कर दो बोल तो बता दो डिपार्टमेंट ऑफ रेडियोलॉजी
Thank you.
Thank you, sir. Thank you, Professor Vinay Sharma, sir, and Professor Sameer. I'll request Dr. Samren Narayan. He will give his presentation on imaging in orthopedics. Okay. He is head of the Department of Radiology, Radiodiagnosis at SN Medical College, Agra. Let him complete. He will go. He has to go.
Thank you, Dr. Pal. Respected senior faculty members, ladies and gentlemen, my dear student. First of all, I would like to thank the organizing committee for giving me opportunity to present this talk. Imaging in orthopedics, as we all know, is a necessity nowadays. What is the need for imaging? Excuse me. Patient code. Actually, Sanjeev Kapoor once said 30 minutes of good grilling in a microwave gives you a good cake. But now I realize 1 hour of good grilling by the senior faculty members give you a good resident. Please, shall I continue? Is it obstructing the view?
Dr. Awak, can you ask the hotel personnel to take this patient from the dais? बेटा सुनो, लेट जाओ, थोड़ी देर लेट जाओ.
So the need for imaging is to diagnose the case, to guide procedures, whether for diagnosis or therapy, for follow-up. Then whenever we need imaging, this is the universal question we all come across in our mind. What modality should I use for this particular problem? As there was some discussion about whether you should go for MRI or not, whether X-ray is okay, whether you should go for CT scan or not. So in next 25 minutes or so, I will be discussing on different modalities so that you can be able to answer at least a part of it, that yes, this is the modality I should go for in this case.
Thank you.
Thank you, dear. So these are the options we have when we talk about imaging: X-ray, CT scan, MRI, ultrasonography and Doppler. Then we have fluoroscopy, arthrography, angiography and isotope scan. Coming to X-ray, it is the most frequently used modality for evaluation of bone and joint disorder. It's an electromagnetic radiation, and X-ray when passed through the subject, some of the energy is absorbed, rest passes through the patient and hits the film plate. And it is that X-ray, the X-ray that is reaching the film creates the image by blackening the film. So if you look at this chart, if on the left side of the screen, you have the source of X-ray, on the right side is the imaging plate. So if 100 unit of X-ray is coming from the X-ray machine and it is hitting the patient, along a line there are different tissues in the body and everybody is contributing in formation of image by absorbing a part of it and allowing the rest of the X-rays to go. And you see on the other side, we have about 36 unit of X-ray reaching at one place and about 10 unit of X-ray reaching at other place. And so what we get, as you know, as we just talked about, X-ray blackens the film. So in the area where there is 36 units of X-ray reaching the plate will be more darker than area where the X-ray reaching the plate is 10 units. And this is how image is created. So what we get, air, it does not absorb any of the X-rays. And so the blackest of all. These are the tissues which we have. Then fat, it will be gray-black, water, gray. When we talk about water gray, see other tissues that forms a similar image are muscles, nerves, tendons, ligament and vessels. And all these structures have the same density and therefore hard to distinguish on plain X-ray. You cannot distinguish them differently on plain X-ray. You cannot say for certain. If at times you might say that yes, this is this muscle shadow, just because you have got some fat adjacent to it giving a fat plane, and by knowledge of anatomy, you can say that this is this muscle or this particular ligament is there. Then bones and contrast medium give the white color on the X-ray film because it absorbs most of the X-rays. When you view the radiograph, in view box, film is always positioned as if patient is facing the viewer in anatomical position. Hands and feet are placed with finger and toes pointing upward. Never place the film in the view box when the toes and fingers are pointing downwards. You might fail in the examination. Lateral views are placed on the box in the direction that the beam passes through the body. When you interpret any X-ray, this is the basic A, B, C and S. A for adequacy of the images and alignment, whether it is cortical, different lines, different views. Then B is examining the bone. C is the cartilage and S is the soft tissue. So this is a normal X-ray we always get. That is, when you image an X-ray of knee, you write the prescription X-ray, AP and lateral view. These are the things we get. But at times you might need some additional views, like this is skyline view for patellofemoral interface. Similarly, this is the cervical spine where you get the normal standard view of AP and lateral, but you might need additional view like oblique view for neural foramina. These are the neural phenomena which you see in the oblique view. Similarly, next, when we look at the alignment of bones and the other lines, then you can diagnose the lesions like fractures very nicely if it is seen out there. This is the Colles fracture. Nothing to tell extra about this. I'm talking about the concept of different modality. Then we go for B, that is bone density. In bone density, we assess the bone in two patterns. One is the generalized bone density and the local lesion. In generalized bone density, we assess the contrast between soft tissue and bone, the contrast between cortical margin and the cancellous bone. And this loss of contrast, blackening and whitening. Black and white is the contrast, the difference between the two tissue. And this loss of contrast gives you that there is loss of bone density. And bone density, loss of bone density, what you call osteoporosis, in radiology, we call it osteopenia, because this is the lack of contrast, there is loss of bone in the X-ray. So this is a normal X-ray. No, this is an X-ray, a photograph of a bone showing normal cortical thickness and the spongy part, and this is the bone where the bone amount is decreased, the cortex is thinned out, spongy part is thin and broken. And what you get on X-ray, when you image this particular spine, what you get is the thin cortical line. Normally this is slightly thicker. So if you are getting thin cortical line, not very well defined, spongy bones are looking relatively dark, and you say that this is an osteoporotic bone. When you go for the local lesions, we define the lesions by its nature, looking at the margin, looking at the location. We also define by saying whether it is osteolytic or bone forming. So these are benign lesions. Some of the benign lesions, what you see is the nature, where the lesion is, what is the margin, where the zone of transition is well defined, where the margin is sclerotic, whether the cortical tunneling is there, where there is soft tissue extension is there. And this type of lesion, definitely especially when you get a thick margin, a sclerotic margin, you are